So what are we talking about today? We're talking about emerging research and clinical trials for smoldering myeloma patients. Now, some of you might be MGUS patients, some of you might be active myeloma patients. You're welcome to be here, and we're excited to have you here. Our content today mainly will focus on smoldering myeloma, although there will be some questions about precursor disease, which includes MGUS as part of the discussion. So Dr. Joseph is passionate about precursor myeloma. That's one of her things that she's very interested in. And so that's why I invited her to come with us today and discuss this. Let me introduce her formally to you. She's the assistant professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine. She's board certified in hematology and medical oncology and specializes in treating patients with plasma cell disorders, including multiple myeloma and amyloidosis. She's also an active clinical researcher in the fields of multiple myeloma, amyloidosis, and bone marrow transplant. She's a member of the Clinical and Translational Review Committee in the Discovery and Developmental Therapeutics Research Program at Winship Cancer Institute and serves as the Director of Morbidity and Mortality Conferences in the Department of Hematology Oncology. She co-leads the Winship Summer Scholars Program, which provides high school students with a unique immersion experience in a cancer research laboratory. Dr. Joseph, I'm really excited for this, and I hope you are as well. Thanks for taking the time to be here today.
Yeah, absolutely happy to be here. And thanks so much for inviting me to come back.
Yeah. So let's just start, I think from the very beginning. So you get a patient in your office. I kind of would like to know if you see more patients, if you diagnose patients, or if diagnosed patients come to you for kind of that second consult. And then what are the, like MGUS or smoldering, what's the most important thing that you want these patients to know?
Yeah. Great. And just to echo what Audrey said, we did one of these a few months ago, and I think it really helped to have your questions, of course, to answer, but also just to guide, what we talk about, because it sometimes can be hard to know who's on the call and what you know and what you don't know and what you really want to hear about. So I think to start with your first question, who do I see? So I'm a academic physician. So I work at Emory University. And so we're a referral center. We have a large myeloma program. And so majority of the patients that I see are referred in. And we see folks all over the Southeast, including Northern Florida and Alabama and Tennessee and even some of the Carolinas. So I would say most of the time I'm seeing patients who have already been diagnosed and they're coming to me for a second opinion. I think within our system, we now have a precursor clinic that's been open for a few years that we specifically see MGUS and smoldering patients within that clinic. And so we see more, just abnormal aspects and what do we do? So we see more new diagnoses there. But for the most part, I'm seeing particularly in the precursor space, people who've been diagnosed, at least with some kind of undefined plasma cell disorder, and they're coming because they want to clarify the definition. I think sometimes in the community with definitions evolving, there's sometimes they want a second opinion. Is this really smoldering or is this symptomatic myeloma? And then kind of what can we do? Because so much has changed in the smoldering myeloma space. So I'm wanting a second opinion on that. And I think encouragingly, we're seeing a lot more referrals for smoldering, specifically MGUS too, but smoldering also, which I think is a really encouraging awareness that the field is moving and changing. 10 years ago, smoldering, we don't do anything, and I'm going to keep them in my practice until I see something different. But that is percolating and that's changing. And so we're seeing those patients earlier to comment and also to at least have a discussion about trials or anything interventional or non-interventional that we can offer those patients. Second question, I think, was what do I think about and what do I want people to know with MGUS and smoldering? So, I think a lot of people, unfortunately or fortunately, when you have a precursor condition, if you come to see a specialist, you're coming to the Cancer Institute of wherever you're going. And so that often causes a lot of anxiety. And I think, unfortunately, plasma cell disorders, in my experience, are so rare that people don't really understand them or aren't fully equipped to explain them to patients. So sometimes they diagnose you with we find this abnormal protein in your blood. I don't know what it is. And so a lot of people come in with a lot of anxiety because you start Googling and you think you have X, Y, and Z, and then you come to the Cancer Institute. So I think the first thing I usually tell people, particularly with MGUS, but with MGUS and smoldering, is this is a non-malignant, this is a benign condition, particularly with MGUS. And depending on what age you're diagnosed, there's a reasonable chance that you will live and move on from this world with MGUS. And that it's really more about monitoring. And then with smoldering, there are many different buckets and flavors of smoldering. So it's really about learning what risk group or what type of smoldering myeloma you have, and then understanding your options, which is, I think, really can be really helpful for some folks, because I used to have more of the conversation of, well, you have smoldering, but there's nothing we can offer you, which I think really frustrated people. And so now it's a more robust discussion of, we can do observation, but here are other things that we can talk about, which helps you feel, I think sometimes people feel more in control of their diagnosis and feel like they can be more active about what they have.
Yeah, very well said. Thank you. I think you hit the nail on the head that smoldering and MGUS are such anxious diagnoses, because it's when will the
Right.
the hammer fall? Is that the phrase, And it's so much anxiety already with going to the doctor's office. And then sometimes it can be hard when you get this diagnosis of, well, we don't know what's going to happen
Right.
to. And
Right.
so having a physician like you who's compassionate about that fact is important. Tell me why. We're getting a couple questions, super exciting. Please keep those coming in. Tell me why precursor condition is one of is a passion of yours. What makes you excited about the emerging research? And I guess that's two questions, and what makes you excited about the emerging research in the precursor field?
I think, for me, a lot of the interest was, I kind of came in when when trials were starting to read out. And so I found it very exciting that there were things that we could do to kick the can even further down the road, and even potentially prevent, right? That's kind of what we're trying to do with some of the ongoing research. And I see a question about clinical trials, and we will talk about that. And so the idea, particularly for a condition that currently is, we think of as chronic, and for people who are diagnosed in their late 60s or early 70s, to be able to further delay even developing, technically symptomatic myeloma, has a profound potential to impact quality of life. And the other challenge with myeloma is, once you start therapy, as many of you know, you're often on therapy, at least our current standard of care, for forever. There's some kind of therapy, some kind of care, which is also very challenging. So the idea of being able to pulse down that disease and give someone more time off therapy, more time and freedom to live their life, is also really exciting. And I think there's so much coming out about genomics and how molecular things, and how we can better understand really who is at most risk, who really do we need to target, and how best to target it. And so I find that space exciting. Drug development and relapse refractory myeloma is also very exciting, but I think it's a more optimistic view sometimes to focus on precursor conditions, because people are healthier and doing better. And so what can we do in this space is what I find exciting.
Yeah, almost like, instead of how can we treat it, it's like, how can we prevent it, in a way, with
Yeah.
all this research. It is exciting and hopeful. Let's jump into that clinical trial aspect. What are some
Yeah.
clinical trials that you're working on at your local site, and how are they furthering research in the smoldering myeloma?
Yeah. So we were talking about this before, and so I know folks are kind of all over, I'm assuming all over the country, and I think HealthTree has a really helpful way of locating clinical trials. So I encourage you to look into that, because maybe 10 years ago I could have told you everything available, but things are really exploding, and a lot of different sites have investigator-initiated trials as well as industry-sponsored trials. So I'm not able to tell everyone specifically what's available for you, but in general, some of the trials that we have open at Emory we have an ECOG study, which is a cooperative group study called the Deter study, which is open nationally at I want to say 15 sites or so. And essentially, high-risk smoldering myeloma patients are randomized. It's a phase 3 study to receive either daratumumab or Darzalex with lenalidomide and dexamethasone versus lenalidomide and dexamethasone. and that therapy is limited for 2 years and then you stop. And this was basically built upon the previous ECOG trial, which was the E3A06 study, which looked at lenalidomide versus observation. There was a randomization of treating with len versus nothing until progression. And so what they found in that study was that patients who were treated with lenalidomide had a significant reduction in the risk of progression. So at 3 years, 91% of patients on the len arm still hadn't progressed, whereas on observation, only 66% still hadn't progressed. So a significant difference there. The challenge of that study was len was continued until progression. And so that became a challenge for some patients in terms of toxicity. We still have some folks at Emory who are still on the trial, 8, 9, 10 years. But in general, there was a lot of discontinuations and dose reductions required. So the average duration of therapy for all the patients was 23 months, or about 2 years. And so the recommendation out of that paper was for patients with high-risk myeloma, it would be reasonable to consider treatment with len for 2 years. So this is kind of this initial, fixed duration immunomodulatory-based therapy. And so what Deter is asking is len-dex really what we should do, or is using a more myeloma-based strategy? So daralendex has been studied in newly diagnosed myeloma and relapsed myeloma. And can adding that third agent increase efficacy without adding too much toxicity? And so we have that open, and I think that's a really good trial. It's actively enrolling. We also have another trial that's only open at our site, but I imagine more and more studies will start looking at this drug either alone or in combination. And it's called iberdomide, which is a CELMoD, and it's essentially a souped up or more novel version of lenalidomide. And it's pretty much the exact same trial as ECOG, the original ECOG study I was telling you about, which is iberdomide, single agent. There is a randomization where you can get dexamethasone, but only for 4 cycles, because dex can cause a lot of toxicity. And then you continue iberdomide, which is just a pill that you take like lenalidomide, which is 3 weeks on, a week off, for 2 years. And so those are 2 of the trials, therapeutic trials that we have open. There are therapeutic trials around the country looking at, a lot of them are phase 2 trials looking at myeloma-based regimens in smoldering myeloma. So that might be things like KRD or DARA KRD. There are 2 active trials, one in the US, looking at a more curative approach to smoldering myeloma using essentially how we treat myeloma, the same algorithm, which is induction therapy, transplant, and maintenance, which is a more intensive route that I haven't fully been sold on. We don't have that at our institution, but it's also very early and we don't have results, but those types of trials are certainly out there too. And then on the flip, there are many and a growing number of non-interventional type trials trying to look at other things that we could do to affect progression, such as diet and lifestyle things, and as well as just learning more about smoldering in general. So, whole genome sequencing type studies and screening based studies and things like that. So if you either don't qualify for a therapeutic trial, which tends to be exclusive to high risk or sometimes intermediate risk smoldering myeloma, and you still want to do something, there are other types of clinical trials. So for example, Dr. Rishad of MSK has a series of nutritional based studies, which we actually will be opening one of them shortly at Emory, looking at the role of plant-based diet. And there are, in general, are a lot more studies like this looking at different types of diet. So for example, fermented foods and things like that, understanding that the gut microbiome is very important and it has a huge role in the development of some of these disorders. So how can we manipulate progression and development of plasma cell disorders by changing how we eat, essentially? And then there are other trials. I know there's one at Dana-Farber looking at drugs that we use in other conditions and using them in smoldering myeloma. So for example, Dr. Nadeem, I think, is a PI in a study that uses metformin, which is a drug that we use in diabetes and smoldering myeloma. So there are a lot of different types of studies as this field kind of explodes, trying to either learn how to prevent, try to cure, I think would be the second category, or 3, how do we manipulate, which would be prevent, but how do we manipulate with non-therapeutic drugs? and then just learning more. How do we figure out really what is this, what causes this, and who progresses?
Yeah, yeah, thank you. I love how you went through those 3 different things at the end, because that is what's exciting about precursor myeloma is you can get those different options and that there's clinical trials really looking into each one of those as well. A couple questions about if you have slides about those specific studies that you'd be willing to share afterwards.
Sure, yeah. Mhm.
Can perfect. So we'll make sure that the audience gets those.
And if we have time, I'm happy to present them as well.
Okay, let's do that in just a moment. I want to get to a couple other questions. I think you explained them very well, and so using those slides as a resource would be good.
Okay.
However, the audience is going to determine. So if you guys want to see those slides right now, please put that in the Q&A
We
and
can
let
do
us
it at
know.
the end. There's a lot of questions.
Yes. So Jesse asks a really good question. When we're talking about trials, can you explain the difference between phase 1, phase 2, and phase 3? And do those exist in smoldering just like they exist in active myeloma?
Yes, they do. So phase 3, I'll start there because it's the easiest, is essentially comparing a standard of care to a new drug that has already been vetted in phase 1 and 2 trials. Whereas phase 1 and 2 trials are earlier studies looking at a drug in a disease for the first time. So those are often earlier studies where we don't know, with either it's first in human or we've never used that drug in this disease. And so those tend to be dose finding studies. So that means that we start at a low dose, make sure it's tolerated, and then go up or something like that. So phase 1 and 2 are just earlier studies where we don't know if the drug will work and we don't know the safety of the drug. So we go a lot slower, and we tend to use more cautious approach, whereas we now have that information. When we go into a phase 3 trial, we're comparing the drug that we think might be better than standard of care, but we want to prove that. And so, for example, the ECOG E306 study I told you was, at the time that study was designed, standard of care was observation. So that was one arm. And then the new arm was lenalidomide, which had already been approved for the treatment of myeloma. And so we compared those. And then we showed that lenalidomide actually improved what we call progression-free survival, meaning the time to development of symptomatic myeloma. And so that is why some of us at least have the option. I think the option of lenalidomide is reasonable for high-risk smoldering myeloma, though I tend to, if the patient's eligible for a trial, I tend to promote those because I think there's a lot more to learn. But I think lenalidomide is certainly acceptable.
Yeah, thank you. So a follow-up question to that. How do you know who to treat and when to treat them?
Yeah, so this is how I approach smoldering myeloma. So for low risk smoldering myeloma, and I tend to use the 20-20 model, which is basically for how many risk factors do you have? So one risk factor is, do you have more than 20% clonal plasma cells in your marrow? That's one. Do you have an M spike or a paraprotein over 2 grams? And then is your free light chain ratio over 20? If you have 0 of those factors, you're low risk. This is the Mayo 2018 criteria that some of you might know. If you have 1 factor, you're intermediate risk. And if you have 2 to 3 factors, you're high risk. If you're in the low risk category, you have an MGUS-like disease. And the median time to progression is roughly in the realm of 9 to 10 years. And so I don't think it makes sense to treat that group of patients because the toxicity versus benefit just isn't there. For an intermediate risk patient, those patients weren't uniformly included on the ECOG study. So I don't treat those patients with Revlimid, but we do have clinical trials for those patients. So if you're interested in something, I would offer you a trial. So for example, the iberdomide trial that I talked about earlier is open to intermediate risk patients. I think that's a perfect trial. And again, the reason for this is not to deprive you of therapy, but to make sure that we're not causing more harm than good. And so if you have such a low risk of progression, we don't know exactly what this drug will do. And there is toxicity. Even if it's well tolerated, there's toxicity, there are doctor's visits, there's changes in the quality of their life. So we want to make sure that we are making a good decision about who we're exposing to these drugs. And then for high-risk smoldering myeloma, like I said, I do think treatment is a good idea for those patients. So standard of care, as someone was asking, used to be, in my opinion, watch and wait. I do not think that's the standard of care. And I think most of us would agree to that, at least in the academic community at this juncture. I think the risk of progression is high enough and we have enough data that I think treatment makes sense. So for people who are either not interested in clinical trial, or for me, a lot of folks don't live near my center. And so if clinical trial is just not feasible for X, Y, and Z reason, I think lenalidomide or Revlimid, single agent monotherapy without dexamethasone, I get asked that a lot. I would just do monotherapy for 2 years is appropriate. I will just caveat that some types of patients, some patients are treated in the community with their docs are getting Revlimid without seeing a community doc. I mean, an academic doc. And I would just caution against that for 2 reasons. One is I want to make sure that you truly have high risk smoldering. And 2 is on all these clinical trials, we collected stem cells after 4 to 6 cycles of drug, because the longer you're on Revlimid, more challenging it can be to collect stem cells, and upfront transplant is still standard of care for symptomatic myeloma. And so if you want to have that discussion of being treated, you have high risk smoldering myeloma, but you are not 100% uninterested in trial, I guess the first thing I'd say is at least talk to somebody, because you don't know what's available. So I would at least have that conversation. And 2 is I would have an academic or a transplant doc on your team so they can talk to you about the role of stem cell collection and how that is done. I forgot the original question.
It's okay. I kind of did too.
Okay. I think it was how do I approach? And so, So for high risk,
Who
I
to
would
treat.
do Len-off study, or I would do a clinical trial.
Okay, perfect. I did forget because so many amazing questions are being asked and I'm trying to figure out which one to ask next. But Judy's asking a good question here. Are there certain genetics in their smoldering myeloma? This example was monosomy 13, but is there certain genetics that could make them high risk versus the 2220?
Yeah, so monosomy 13, so the IMWG risk stratification model did include high risk cytogenetics, but monosomy 13 was not included in that. So I would say no for that specific one. The high risk features we think about are del17p, 414, and 1416, as well as I believe gain of 1Q was included in that. When you look in general, even having that high risk feature doesn't tend to bump you significantly. So if you're low risk, you're probably still going to be a low intermediate or something like that. It's something to take into account. And it's certainly included more and more in different clinical trials. I think the other challenge of some of our smoldering trials is we're using, particularly globally, we're using different definitions of what high risk is, which is problematic because then it becomes hard to apply that, which is why I'm kind of a proponent of the 2220 model, because it's very easy to apply, particularly in the community for people who don't see myeloma all day, every day. You don't have to use a calculator or anything fancy. It's easy to do. And so the iberdomide trial, we wrote that with 2220 specifically for that reason, because we can easily classify people. It can be uniform across the board.
Yeah. So an additional question, as we talked about, with these low risk or MGUS like smoldering myeloma patients, even with MGUS, how often are you asking them to be tested to track that myeloma? Or
good question.
Myeloma?
So do you say for MGUS and for low risk? So for MGUS, what I tend to do, so a lot of the time, what's helpful is time, meaning to be able to follow the patient, follow you for a period of time and understand how your disease is evolving. So, what I tend to do for new MGUS patients, I see you again in 6 months. And if things are stone cold stable, I do annual monitoring. There's some folks who've had MGUS for 15 years. I think every 2 years is probably reasonable as well. That's probably not disease that's moving, particularly as we get older into our 90s and things like that. For low risk smoldering, the guidelines are about 6 months, 4 to 6 months. So again, that depends on the person's labs, and you always reserve the right to change your mind. So if something changes on a set of labs, and I'd like to see a little sooner to confirm that was either a blip or things are stable, I do that. I mean, the thing with myeloma in general, or plasma cell disorders, is that protein will bobble. It will go up, it'll come back down. you could check it multiple times the same day, you're not going to get the same number. So sometimes people panic because their arm spike will go from 0.23 to 0.3. But I say, just give it a second, because the next time it will go back down to 0.25. So what's really more helpful is the trend, right? So if it goes from 0.23 to 0.3 to 0.5, okay, maybe something is evolving here. Let's keep a closer eye. But if things are just kind of hanging out in the same range, then, I think 6 months is perfectly fine for lower smoldering. Intermediate is kind of 3 to 6. And for high risk, I tend to do 3. I mean, the challenge about high risk, and the reason that I think it's appropriate to treat, is there's no interval that you could see someone and guarantee that you will catch them before they get end organ damage. That's the challenge. I could see you today, you could get something next week, right? You can't always pick it up. And so because of such a high risk of progression, that's why we recommend, intervening, because the whole point, besides trying to really prevent and delay and all these things, the real point is trying to prevent end organ damage, which is why we changed the definition of what myeloma is in general, so that we treat people a little bit sooner.
Yeah, very well said. Thank you. Let's say somebody's trend is increasing, for example, those immunoglobulins was numbers, is what Pamela is saying, continue to rise. Would you order a bone marrow biopsy on an MGUS patient whose trend is increasing?
Yeah, I think, I try to get a baseline unless it's a really small paraprotein, but I think if I'm seeing ongoing progression, there's no magic number. I wish I could give you a specific guideline, but if I'm seeing, significant bumps, I probably get a marrow. And if the marrow is showing 10% or more, I'd probably get bone imaging, because then we're in the smoldering myeloma space. You just want to be sure that you're not missing anything.
Yeah. Yeah. So there was that question earlier about, why is high risk smoldering myeloma standard of care watch and wait? Even though it's not, they brought up a good point later that if you don't live next to a center that's doing one of these, sorry, I put it in the answered. So if you're looking for it, it's in the answered.
Oh, okay.
But they brought up a good point that if you're not living near one of these clinical trial centers, it can be difficult to be treated with one of these new and upcoming trials. And therefore, one of their reasonable options is watch and wait. Is that true, or are you able to communicate with the community oncologist in a case like this of, no, the standard of care right now is lenalidomide and really should be used?
Yeah, I mean, I think so. For me, and I would probably say most of academic myeloma docs, majority of my practice, I don't treat them. Majority of my practice drives in periodically or resume, and they have a local oncologist. And I think the benefit of lenalidomide is that's a really easy drug to give. Oncologists across the country are very used to that drug, and it's just a pill. So I still think, and this might be more just taking time for this to percolate into the communities. If you have high risk smoldering, you cannot come to an academic center for a trial, but you have high risk, I would still recommend Revlimid off trial. And you can do that with your community doc. I can help. The academic doc in the area can help see you periodically, to speak to that doctor to make sure that, they don't have questions. And like I said, the only caveat is, let's chat about stem cell collection. But I think that the benefit is you can absolutely get that close to home.
Yeah.
And I think to answer the second part, if you want me to, about ASCENT. So
yeah.
Yes or no?
Explain it. Yeah, if you explain.
Okay. So the second part of this question is about the ASCENT trial, which is one of the trials I was talking about with this kind of curative approach, using more intensive induction and transplant and things. If you look at the progression-free survival of ASCENT, and I'll make sure I'm not getting confused with Gem Caesar. Yeah, the 3-year PFS of ASCENT, meaning how many people still hadn't progressed to 3 years, is exactly the same as ECOG, which is just Revlimid. It was 93%, 94%. It was 93%, meaning that maybe depth of response isn't what we need in smoldering. It is what we need in myeloma. We know that, but we're slamming people with therapy. And if you look at the toxicity, what you'll see is the toxicity they compare it to myeloma patients treated with the same regimen. They say the toxicity is not different. That's true, but the toxicity between daracarity and Revlimid is profound. Mm-hmm. There's a much higher risk of cytopenias, infection. There were deaths on that trial, mostly infectious, so may or may not related. So that's a bigger risk to take. And as of now, they have not shown that there's a PFS benefit. So that's why, in my mind, first of all, the trial's not over and we don't have enough information. So, it's just too early to say. But I think as of now, I absolutely would not recommend that approach because I don't think we have the data for that. Whereas for Revlimid, it's a much lower risk in terms of side effects and things that can go wrong. And we have already seen in a phase 3 trial that there's a benefit. So
Yeah.
that's why I think that's a more appropriate approach.
Janet's wondering where that ASCENT trial is being administered, if you know.
I don't know, but I can look it up.
Okay.
It might be on HealthTree.
I was just trying to Google it and at all.
If you Google those trials, on the clinicaltrial.gov, they will have a list of sites of where those are open, and there's usually a PI listed, so you can reach out.
Yeah. Our yes, we have a clinical trial finder on HealthTree. Specifically, it's even more accurate if you have a HealthTree Cure Hub profile, meaning that in our research portal, you have consented to give your information or upload your information yourself so that our system is able to recognize what clinical trials you qualify for as an MGUS or smoldering patient, and then, or active myeloma patient. And then you're able to look at the trials that are open, enrolling near you, that you qualify for already. It's able to sift through a lot of them. So I'm just having a hard time. There's probably a bug, like when I'm looking or I'm spelling it wrong. I mean, let's be honest, if I'm looking for the ASCENT trial, but I will send a link to that clinical trial finder in our email after this, because it's important that you guys are able to look up what's around you, what's available to you, and be able to coordinate your care that way. Valerie asked a good question. Is it true that if smoldering doesn't progress within 5 years, that it's less likely that it will progress at all?
In general, yes, which is why a lot of those patients are excluded from trial, because this is exactly the point I was making about time is our best friend. Is 5 years you're not showing any risk of progression, you're kind of downgrading yourself in terms of risk because you're just not showing that evolution. Even if you're high risk, because what we know is most people are progressing around the 2.5, 3-year mark. So if you're getting to 5 years, 6 years, you're biologically, your disease biology is telling us it's not this more aggressive type.
Thank you. Someone's saying enrollment is closed for ASCENT. There might be similar trials like ASCENT that are still enrolling, but thank you for that information because that's good. It's hard to keep track of all of them, as you said.
The other curative trial is Gemcitabine, but that's not here.
Okay. All right. So a couple questions are asking about immunotherapies in precursor myeloma, specifically CAR T. So if you don't mind briefly explaining what CAR T is for people who might be unfamiliar, and then explaining why or why not you think it would be a useful treatment in the precursor myeloma stages, specifically smoldering.
Sure. So CAR T cell therapy is essentially taking your T cells, the patient's T cells out, and engineering them to be more effective and targeted against your own myeloma. So what can happen, particularly in folks who've had myeloma for a long time, is your T cells can kind of wear out. And T cells are the cells in your immune system that are supposed to kill your cancer cells. And so we take them out, we kind of soup them up, so they're like superhero T cells, and then we infuse them back into the patient after a little bit of chemotherapy for those T cells to essentially engage with myeloma cells, cause immune activation, and kill those cells. So we have 2 CAR T cell products in myeloma, ide-cel and cilta-cel, that are both approved in relapsed refractory myeloma for patients who have had more than 4 lines of therapy. In general, things take time, and everything in myeloma, everything in cancer in general is approved initially in the relapse space, right? Because that's where we can study new drugs, and then they start to move up. So already we're seeing CAR T in clinical trials being used earlier, newly diagnosed, non-transplant eligible, earlier relapse, et cetera, which is probably where it belongs, because I think the point you're making is by the time we get to 5th, 6th, 7th line, it can be really challenging to even deliver CAR T in general because of the manufacturing time. It can be hard for patients who are really sick and have quickly evolving disease to even get them to CAR T, which is where kind of bispecifics have come into play. Those are off the shelf. It's kind of a faster version of CAR T. It's a slightly different process, but a same similar mechanism. I mean, I think the simple answer to your question is, again, the point I was making about toxicity. We just don't know. There are trials looking at bispecifics, in smoldering. And so we might learn more about that. I think the key is fixed duration of those drugs in those patients, but right now it's just too soon. We don't have the information, and I think the toxicity is too high. And I think we also don't know if that kind of activation will create the kind of remission or cure. We just don't have that information, because even with the ASCENT trial and GEM2R, we're being much more aggressive, and we're not seeing, at least as of yet, we're not seeing significant differences. So, one of the theories about smoldering myeloma, I had a slide about this, is that, what really separates smoldering from myeloma isn't necessarily the disease itself, but about the immune system's ability to control that clone. So meaning your immune system is aware that they're abnormal cells, but it's keeping it under check. And that there's something about a change in that immune control that eventually it exhausts or it wears out, that allows that clone to grow. And so when you think about it that way, if you start blasting people with therapy that is going to affect that immune system's ability to function, you're risking that clone, you're risking that the immune system can't do its job and that clone is going to progress, right? And so that's one of the reasons that some of us are more on the camp of less intensive fixed duration immune modulatory type therapies, because lenalidomide not only kills myeloma, it also affects the immune system's ability to function. There's multiple different ways that lenalidomide works. And so it's not just about killing myeloma. You have to think about what you're doing to the whole immune microenvironment with these therapies. These are very intensive therapies. They have a lot of side effects. And so it's a long-winded answer too. I think we don't know that yet. And there's a lot more risks with some of those therapies.
Very well said. I like it that, I don't know. I know that what you're saying is true, but when you put it that way, it's like so clear, that it's a whole body operation when you're given these drugs, for lack of a better word, to fight the myeloma, you're affecting your whole body. And so then it's like, anyway,
We just want to be measured about how we do it, which is why we have regulatory bodies and why things can sometimes feel like they move glacially slowly.
Yeah. Valerie has a question about if her oncologist is monitoring her progress via light chains, is this a best method to track progress? To everyone here, I think you should answer that question. I think it's a good one. I just want to make sure, sometimes people use oncologist and specialist interchangeably. So Valerie might have a specialist already, but anybody here who does not work with a myeloma specialist, I don't want you to feel like I have to have active myeloma to be seen by a myeloma specialist. In fact, it is such a wonderful choice as a precursor myeloma patient to enter the world of myeloma specialty, because they're doing it every day. They're talking about it every day. They're researching it every day. It's on their minds all the time, probably more than you would like, Dr. Joseph. And so these people are so involved and care about your care and just are, I don't know, this is my soapbox for today, but myeloma is such a complicated disease. Even in the precursor stages, you want somebody who knows this like the back of their hand. And general oncologists are amazing. They have so much in their brains that it's impossible for them to keep up with all of the research in myeloma, especially what's being done in the precursor field. So if you don't have a specialist, get one, please get one. And then the question now is yours, Dr. Joseph. Is light chains a good way to track it? How do you track the majority of your patients'
Yeah.
precursor disease?
Yeah, so it just depends on what your specific disease is secreting. So a lot of plasma cell disorders secrete a heavy chain with the light chain. So you might have heard something like you have IgG kappa MGUS or IgA lambda smoldering or something like that. Some disorders, some dyscrasias, excuse me, which just means plasma cell disorders, only secrete light chain. So it really just depends on what specifically is the marker of your disease moving. So if you only secrete, if your myeloma or smoldering myeloma only secretes light chains, then yes, we follow light chains. And that will show up in your labs, generally as we'll say free kappa light chain, free lambda light chain, free light chain ratio. And only one should be elevated, right? So we all have kappa and lambda in our body, but when you have a plasma cell disorder, you have one cell that has mutated and now spitting out a ton of antibody that's all the same. So if you have a kappa light chain smoldering myeloma, the kappa should be higher than the lambda, the ratio would be abnormal, and we would follow both the kappa and the ratio. If you have a disorder that has a heavy chain and a light chain, then we follow both your free light chains and we follow the heavy chain number, which is reflected in what we call the SPEC, or the serum protein electrophoresis, which is sometimes, all the different hospitals label it differently, but it could be M protein, M spike, paraprotein. Ask your doc, what it is, so you can follow it along. And we also look at immunoglobulin levels. So if you have an IgG myeloma, then we will also follow the total IgG as well. So free light chains might very well be the right thing to measure if that's specifically what your myeloma secretes.
Yeah, I had to make sure I wasn't muted. Yes, that is a good way of explaining it. Thank you. Okay. So there was a question here. I'm trying to find it where they asked, what's next? You treat your patients. Oh, right here. So your patients that are wrapping up a trial, whatever that trial may be, if their response has been positive, do you go to other medications or other trials, or do you try to go med-free with them, medication
Good
free?
question. So what I do is they complete the trial and that's it. So they'll do 2 years of Revlimid or 2 years of the trial, and I stop and I watch because that is how the trials were designed. And a couple things. So one is there aren't clinical trials really available for smoldering myeloma patients who've been treated, right? That's just not where we're at. That'll probably evolve, right? Because that's where we're moving. There's going to be more and more smoldering myeloma patients that have been exposed to myeloma drugs. But if you have been treated with Revlimid for 2 years, there's no smoldering study that I know of that is available for you. And so what we do at that point is we monitor just like we did before until progression to symptomatic myeloma. A question I have, which is a research question, is there a role for retreatment when you start progressing again before you have symptomatic myeloma? So meaning, let's say your M spike was 3 when I started treating you, it dropped down to 0.5, and then we start monitoring you, and 5 years later, it's back up to 3, but you don't have symptomatic myeloma. Should we retreat you? Should we repulse you with Rev for 2 years? I just don't have that information for you. I think it's a very interesting option, and I think theoretically that could work, but we don't know. So as of today, I would treat for 2 years and then I would watch. I think someone said that they were treated for 2 years. What would you do now? And I would just watch.
Now, is that sorry, thank you. Now, a question here is the Revlimid option only available FDA approved, I'll say, for high risk smoldering, or does it include intermediate risk as well?
So the way that trial was designed at the time, 2220 didn't exist. And so the patients who were included on that study were a hodgepodge of what we now think of as intermediate and high. And I actually think there was some low as well included on that study. And so when they did a subgroup analysis later, applying retroactively the 2220 model, the patients who benefited the most were high-risk patients. If you look at the PFS curve, so how we kind of look at the difference between two therapies, they overlapped in intermediate risk, meaning we couldn't really tell. And some of that is because there weren't enough intermediate risk patients on the trial, but it just wasn't a clear-cut benefit. Whereas for high-risk patients, we could really see that benefit. And so that's why out of that study, and my interpretation of that study is that those patients can benefit from Revlimid. But for intermediate, I don't do that off trial. I think there's still a role potentially of treating those folks, which is why I included them in the iberdomide study, but there's more to learn about that. But that's why I only do it for high risk.
Yeah. I see a couple of patient questions here or comments about how, and this certainly is not new to this session either. Specific doctors are not willing to either prescribe a medication that that patient wants that is approved, or they're not willing to consider a trial when the patient has asked. Are those good options? I mean, I'm going to say seek a second opinion. Would you agree with that?
Yeah, I mean, I think I'm reading, I'm sorry, I'm reading too,
Oh, yeah.
while I'm listening to you. I mean, I think there's some, Joseph, you're listing, my crude math is telling me that you probably have intermediate risk, 300, yeah. But, I think always get a second opinion is kind of the take home of this. And again, because it's newer and evolving, I would go to an academic center. It doesn't mean you have to be treated there, right? But and there are large myeloma programs across the country, but there are academic sites in every state. If you're able to get that second opinion, so you can just have clarity on the diagnosis. And then I think sometimes community, in my experience, community oncologists are more comfortable when they feel like they have a guide or a partner. If it's just not something that they're familiar with. And we were talking about this before, to their credit, a community oncologist has an insane amount of information to know. So it's not, I'm not trying to be disparaging in any way. It's not feasible to stay up on every single thing and every single type of solid tumor. So I think if you're hearing something that you think is incongruous with what you're hearing here, then I would absolutely get a second opinion. I think myeloma is rare enough and evolving fast enough that you're always going to benefit. There's actually studies that people do better with myeloma when they're seeing someone who's a myeloma specialist. So it's always a good idea. And even when people see me and they say, should I get a second opinion? I say, yes, get more information. I'm not offended by that. No one should be. It's your body, it's your life. And if there's something that doesn't quite jive with you, or you want more information, I think it's always worthwhile to get a second opinion.
Yeah, very well said. Let's do rapid fire and try to answer as many of these as we can. I'll start from the top. So Sandy's wondering, is it better early treatment to nip it in the bud or wait as long as you can so new drugs develop?
Sandy, good question. I think my answer would be, if you have high risk smoldering, I would treat you now, and we would use those new drugs if and when you progress to symptomatic. Because I think the evidence, particularly for IMIS, is good enough now. And it doesn't, in the Spanish study, when they treated with Revlimid and dexamethasone, we're not creating a more resistant disease. They have shown that. So I think there's benefit of now. I worry sometimes about watching that we might miss a window. So I think it's certainly up to you. I don't think it's wrong to watch. Some people really just don't want to be treated until they have to be, and that's fine. That's okay. But I think if you're willing to be treated, I would, particularly if you have high risk, I would probably recommend that you go ahead and be treated now.
Thank you. Jessica is wondering, how important is it for newly diagnosed smoldering patients to take their time in the decision-making process, like should they enter a trial? Because it's not as urgent, do you have your smoldering myeloma patients consider lots of options? Or do you really just think that entering trials is, I mean, it's a case-by-case basis, of course.
Yeah,
But
well, sure. I think the answer to that is you should absolutely take your time and do what's right for you. I would never want anyone to feel rushed into something, that they're not ready for, they don't understand. I will say one thing to just be cognizant of as you're taking your time. I mean, I think the benefit of smoldering is you do have a little bit of time. You have a luxury of time. Things aren't hopefully going to change tomorrow, so that's good. I referenced this earlier. I would just make sure if you're looking at a trial specifically versus off trial, that trials do tend to include, as eligibility when you were diagnosed. So I would just keep that in mind, when you're talking to your doctor about eligibility, what amount of waiting time would make you ineligible, just so you have all the information so you can make an informed decision. But I don't feel in general, even for high risk, that there's a rush. It's not symptomatic myeloma where I want to start treating you next week, right? It's,
Yeah.
you have some time.
Yeah. Mary Beth was part of the vaccine trial, which finished last fall, which I'm actually going to ask you a question about in a minute. Has had smoldering myeloma for quite some time now. What are next steps? And this is a common question. You know, we kind of spoke on this earlier. After trial, what is next steps?
Yeah, I wish I had a cooler answer for you, or, something different, but the standard right now is once you've been treated, hopefully you've had a nice response. Hopefully we're seeing nice periods of time where you don't need to be on treatment. But the answer is monitoring. There's just nothing that we know of that's going to help you. And the standard is to wait now until, hopefully you don't, but until you start showing signs of symptomatic myeloma.
Let's talk about the vaccine trial quickly. If you do wouldn't mind just kind of giving a little bit of background on what that is and then what your personal philosophy is on it. I think it's fascinating.
Um, is this the PVX one?
I
Is
think
that what you
so.
were talking about?
Let me see. Oh gosh, I lost it. Where is it? It should be near the top. Yes, PVX 410 vaccine trial.
So yeah. So I mean, I think all immune-based strategies are really exciting. So essentially this was using a vaccine to try to stimulate an immune response against smoldering myeloma cells. And so again, I think any immune-based therapy that's trying to harness the impact, the power of your own immune system to fight back, and particularly so you're not taking regular therapy forever, is really exciting. Um, yeah, but I think again, we just don't have, it's just early data. But I
Yeah.
think any of those types of trials, I think vaccine trials, even in myeloma, and bispecifics and things like that are really exciting. And just to kind of harness back to the CAR T question that we had, it's an interesting idea and concept, but it's early, and we don't have enough to start using it.
Yeah. Yeah. Judy's wondering, do you suggest taking K2 and CA? I'm not sure what those are, or going on a bone density drug when you have SS and I'm assuming that's smoldering and osteopenia.
So I don't know what K2 means. I'm assuming CA is calcium. So osteopenia is more common. Osteopenia or osteoporosis, which is weakened bones, is more common in patients with MGUS and smoldering than the general population. So I think it's perfectly reasonable to go on a vitamin D calcium supplement. I don't routinely put people on bisphosphonates for that, but I mean, but having said that, I think a bone density scan makes sense, particularly at a certain age. And if you have osteopenia or osteoporosis, that's something I tend to defer to endocrinologists to use bisphosphonates, other bisphosphonates like Fosamax and things. I think that's perfectly appropriate. Yep.
Dawn is wondering if rheumatoid arthritis could make you ineligible for a clinical trial, and then is also wondering why Rituxan.
Yeah, so sure. So rituximab or Rituxan is an anti-CD20 monoclonal antibody, meaning CD20 is the CD markers are on the surface of cells, and they're different markers on different types of cells. So B cells and T cells, they all have different markers. So CD20, which is what rituximab targets, is not on the surface of plasma cells because plasma cells are terminally differentiated B cells. So they're not quite the same as a regular B cell. So Rituxan doesn't work in myeloma because there's no CD20 on myeloma cells. So that's why we don't use Rituxan. In terms of being eligible for trial, it really depends on how uncontrolled the rheumatoid or how controlled the rheumatoid arthritis is. So some trials exclude patients who are on other disease modifying agents, or if you're on, like methotrexate and things like that, that might exclude you depending on the trial. Having rheumatoid as is doesn't necessarily exclude you from trial. And I will say, in general, there's a higher incidence of MGUS and plasma cell disorders in patients who have autoimmune disorders. So that's not uncommon.
Yeah, okay. Jesse's wondering if you're familiar with the Pangea calculator online to determine chance of progression.
Yeah, that's also through Dana-Farber, I believe, and that's with evolving labs. Am I right, Jesse? I think fish, so like I said, the actual model that I use does not include cytogenetics, because so even though there is a risk there, it doesn't tend to change significantly. It's a more in-depth calculator. So I don't necessarily take it into account, but there's certainly a lot of data that particularly some of those high risk cytogenetic features are important. I mean, I think in general, we're working, if you kind of do a quick PubMed search, there's a lot of data and a lot of new papers coming out on how we best risk stratify patients. The Mayo 2018 model and the IMWG 2019 is just two of the more recent models. It's changed. Before that we used the Mayo 2008 model, which was different, and it'll continue to change as we learn more about other molecular things and whole genome things that we should be including. And so that might change too. But I think right now I don't tend to include fish when I stage patients.
Yeah. Yeah. Well, there are just a lot of really great questions here, and I am sad that we didn't get to all of them, but we were able to have a really great discussion, at least I thought, and get a lot of questions answered. I'm going to finish here with Mary Beth's question, which is, are you aware of any smoldering myeloma trials that show that early prevention is increasing overall survival, not just progression-free survival?
Yeah, the Spanish study that I referenced, the Pathema, I'm getting tired. Pathema study, yes. It was originally published in 2013, maybe, by Dr. Mateos, and that looked at Lendex, so lenalidomide, Revlimid, and dexamethasone versus observation, and they have shown an overall survival benefit. So the good news in myeloma is it takes a really long time to show a survival benefit because you guys do so well. So whether it's smoldering or symptomatic myeloma. So the ECOG study and Ascent and GEM-CSAR and things will take hopefully a while to show that. So they have not shown an OS benefit, but we have seen an OS benefit in the Spanish study.
Awesome, thank you.
Sorry. The challenge of the Spanish study is that they used a different model for risk stratification. So that's why I don't use DEX. And I'm just going to do one more.
Yeah,
go 1 minute. Monosomy means that you're missing the whole chromosome, and deletion tends to be deletion of a branch of the chromosome. So if it says monosomy 13, you're missing one whole copy of 13. It says deletion 13q, part of the chromosome, the Q arm is missing. But monosomy 13 is essentially del 13q because you're missing that 13. Symptoms of smoldering, you should be asymptomatic. You should be. I certainly have had patients who tell me they feel tired. That's usually the most common thing, and that might certainly be related. But the idea is that you are asymptomatic, which is why we try to leave you alone. Those are the two quick ones I saw.
No, that's great. That's great. Okay, I'll ask you one more. The neuropathy. I hear of a lot of precursor patients who have neuropathy are unsure whether it's related or not. What are your advice for
them? So there's a whole category of disorders called monoclonal gammopathy of clinical significance, which we're understanding more and more about, which essentially means you have this abnormal protein in your blood. It's small, but it's wreaking havoc. And that can present as a skin rash. If there's dermatologic manifestations, it can present as neuropathy. It can present as ocular manifestations, meaning eye symptoms. There's a lot of different things that can cause, and they're really challenging to diagnose. I think with neuropathy, though there's a relation with MGUS and neuropathy, it's really hard sometimes to prove that. It tends to be more common in patients who have an IgM plasma cell disorder, and there are specific tests and antibodies that we can send to prove that. When it's a non-IgM, it can be harder. I tend to send people to neurology to get nerve conduction studies, and sometimes even a nerve biopsy. The other thing that can cause neuropathy is amyloid. And so amyloid can present even in MGUS and smoldering patients. So if there's no other, I look for other reasons, diabetes, back problems that's causing neuropathy, anything else. But if there's nothing else, and particularly if the neuropathy is getting progressive, then I'm more aggressive about it. But, it can be really challenging because MGUS is not uncommon and neuropathy and things are. So I think it tends to be more of a diagnosis of exclusion and just being really, really careful about that diagnosis because the treatment is chemo, so you just want to be really sure that you're doing the right thing.
Yeah, very true. Well, Dr. Joseph, thank you for your time. Is there any concluding remarks that you'd like to make before we finish up for today?
No, I just thank you all so much for your engagement and coming. I hope that was helpful. I'm sorry that we didn't get, there's really good questions here, and I'm sorry we can't get to all of your questions. But I hope that was helpful. And, um, I said something like this last time. It's even more true for this group that, this is a really optimistic time. I think if you have to have myeloma or plasma cell disorder, there's a lot of active research and movement and a lot of reason to be hopeful. And so I really applaud you for being here and for being part of this community, and I'm sure other communities, and learning about what you have, because that's your power. You're empowering yourself with this knowledge, and it's not a disease that everyone knows about. So you having this extra knowledge and resources is you're really doing the right thing by yourself. So I applaud you. I hope this was helpful. And thanks, Audrey, for having me back. Always
Yeah.
happy to be here.
Awesome. Thank you, Dr. Joseph. We're going to let you go and I'll just finish up with a couple announcements. But you have a good night. Thank you.
Thanks.
All right, to my audience, as she said, I just am so amazed by you, the way that you show up, the way that you educate yourself. I mean, that makes a difference in your care. And you asked great questions. We have a patient experience team. They can't give medical advice, but they can help lead you to find answers to your questions. So I'll make sure to include the patient experience team contact information as well, because I know your questions are important to you and I want to get them answered, or at least lead you to the right direction or the specific question that you can ask your doctor or your specialist, or a way to find a specialist. We're here to help you and I'm passionate about helping you, and you're already doing so much for your care. I want to aid you in that. So thank you so much for being here. I will let you know when our next meeting is going to be. There's going to be a significant shift in this community program. I wanted to make you aware of that, but your education is important to me, as I just said, and therefore this chapter is not going away, but the next time we meet and who is going to be speaking to you is still up into the air. So I will up in the air. I don't even know what I'm saying anymore. So I hope that you guys will be able to attend, and I'll email you when that is available. Other events that you may be interested in: on the 25th, aka tomorrow, is our Black Myeloma Health Community Chapter. We're finishing up May. May is Mental Health Awareness Month, so that's what we're going to be discussing. The 30th at 7 p.m. Eastern is our newly diagnosed chapter. We're going to be discussing maintenance therapy. And then the 31st at 7 p.m. Eastern is the amyloidosis chapter. We're going to be discussing why is amyloidosis so hard on the heart and the kidneys and other functional organs. The link to sign up for any of those events and more events I did not mention is found at the bottom of the slide and will be included in the follow-up email. Special thank you to Amgen, AbbVie, Adaptive, Janssen, Genentech, and BMS. And thank you to each of you, as I just said, for being a part of this community, for taking part in your care. You're amazing. And I hope you have a great rest of your day. Bye-bye, everyone. Thank you.